All right, so it's good to be back in Shreveport after about 13 years ago, around that time. I remember coming to a reentry conference, right when reentry was really starting to kick off, right here in this same convention center. Right now, I'm currently working with LSU Health Sciences Center out of New Orleans as one of the licensed mental health professionals as part of the Spoke Care team. I'm going to explain to you somewhat about the hub and spoke model that is being used by Louisiana for the Louisiana State opioid response. I'm going to give you a language lesson because you know we love acronyms. So there's a bunch of new acronyms right now in the state. So we're going to talk about some of those acronyms, and that way you can have an idea when you're talking to referral sources and others that are part of the opioid response, get an idea what's going on. We're also going to do a brief overview of SBIRT, screening, brief intervention, and referral to treatment, and talk about some motivational interviewing strategies that are used with SBIRT. As I go through that process, I'd like to start off, first I have no financial relationships or commercial interest to report. I'm going to give you a little bit of my history and how I got to where I am today. I'd like to tell people I didn't choose the population chose me. I started off in the early 2000s working with a hospice company. We were providing palliative care. And if you think of the early 2000s, what was going on, if someone was having issues with pain, how did that process go? Give them a scale, right? And if you on a scale of 1 to 10, how strong is your pain, right? And based on what their pain was, what happened? A lot of medication. Interesting thing working as in hospice was that it was myself, I was a chaplain, social worker, nursing, the pharmacist, doctors, a complete interdisciplinary team. And how I got into addictions counseling and working with the hospice company, we started having a lot of clients or patients who at one point had a substance use disorder, and now you're at end of life and you're dealing with all these medications. They were having complications. Also, we were dealing with the family members that were actually in the household. Got to think about just think about the amount of drugs that were being pumped into a household when somebody's on palliative care. Whatever it takes to make them comfortable. Benzodiazepines, Xanax, Ativan, opiates. I learned for the nurses in here about breakthrough pain. I had no idea what that stuff was about. They'd put them on, say, oxycodone or a particular medication that would last for the day, and they'd have Lortabs if they would complain about pain during the day. They were placed on fentanyl patches. Pain medication. So from there, I had very good outcomes working with the clients with hospice, and there was a social worker working there, and him and a couple of partners owned a halfway house and intensive outpatient clinic. And he invited me to go work with them due to the fact of having some good outcomes with the patients that was at the hospice. So went to work there. That's where the halfway house and IOP. So now if you want to put it on the timeline, this is about 2005, 2006. This is what the Access to Recovery program. The unique thing about what we had in the front halfway house were clients who were coming from one of the premier treatment centers, very expensive to go to, and as they were being discharged as part of the Impaired Professionals program, they come to stay with us in the halfway house. It was intimidating as a new addictions counselor because you're sitting in a room and my patients might be a doctor, a psychiatrist, a nurse, people of various professions. And here I was at that point just really moving into the addictions field. So very intimidating, but what I found in that same group was doctors who had been prescribing those medications and who also were struggling themselves, nurses, and right alongside that were other family members. The unique thing that I started to notice back then with opiates compared to certain other drugs, crack cocaine was still very common around that time. Methamphetamines was really just picking up. But when you started dealing with opiates, there was no discrimination. If you look at, I worked a lot in the criminal justice system, still do. If you look at methamphetamine and people on federal charges, it disproportionately targeted and really harmed poor Caucasians as far as it went to prison for long term. If you look at crack cocaine and the way that the sentencing disparities were, it disproportionately harmed poor African Americans. But notice what the key thing was. poor. Criminal justice system, if you have lack of resources, you will get a very bad situation. That's the way it works. People will do anything to an agreement to be free, whether they can actually do that or not. And I'll integrate some of that into the talk. So when I was working at the halfway house, we had the impaired professionals, people who had all the resources in the front. We had a building in the back, and I ran an intensive outpatient program for access to recovery. So I worked mainly with people with low socioeconomic status. People couldn't afford access to treatment, and probably 80% of those were criminal justice involved. And so I got recruited by the sheriff's office to go work for them and start some programs. We started in Lafayette, the Lafayette Parish Sheriff's Office, the first residential treatment center that was within an actual correctional facility, and a few other things that we did there as well. I did a lot of work with LRS at that time. Scope of practice issues hit, and if for anybody who's been in mental health and addiction for a while, integrated treatment was really the buzzword around 2006, 2007. And the previous speaker talked about that. You get a referral coming into the agency if you work in primary mental health or primary addiction. Well, get the addiction taken care of first, then send them to me. Or if you go there, well, no, go get them stabilized with the mental health, then send them to me. So what happened to the client, the patient? They're not getting any services. So finally, they started having a lot more of a focus for co-occurring disorders. The sheriff in Lafayette, we didn't have enough juvenile services, so we implemented functional family therapy. We started an outpatient program for mental health and addictions. That later, when I left the sheriff's office through my private practice, we provide treatment for adult drug court, pretrial intervention, do all the assessments for clients who have a first offense OWI, first offense, the pretrial program in Lafayette, 15 JDC, almost any crime that a person could commit on the first offense, excluding a few, they can at least have an access to get some pretrial intervention. Now, what does that have to do with treatment and providing treatment? What I've learned over time, and it happened very quickly when I started working at the halfway house, is a large percentage, I'd always say 60+% of the clients you work with that have a substance use disorder, have criminal justice involvement with DCFS, and you can go down the line, they're connected in some type of way. And if you don't have the sensitivity and understand how these systems work, I found myself not being as effective as a clinician. One of the issues would happen, it really broke my heart when I first started doing that. Client would have reached 70 days clean. It's the first time in my life I've ever been done that well. And then the next day he doesn't show up to group. I'm trying to figure out what happened. So a few days later you call, oh, that person was incarcerated because they still had lack of resources. They couldn't afford to pay their probation fees. They couldn't afford to do something, or they missed community service because they didn't have transportation. And so now this person, for the first time being that long in sobriety, they're going to now start that off in jail. So as you can tell, I started off as a chaplain. My mission became the criminal justice system in Louisiana. And so that's where I focus primarily. And then we're going to start to segue into this opioid response. In about 2012 or so, there was started having more and more clients calling me at my private practice saying that I need some counseling. If somebody doesn't provide me counseling, they're going to stop prescribing me my medicine. My doctor's going to drop me. And I was like, okay, I don't know what that's all about. As the first person called, I thought, no big deal. I'm not sure, that's not my specialty. And then I got another call and another call, and that became somewhat of a trend. So I quickly realized that this opioid epidemic was really starting to ramp up, but then we started to have a serious problem with access to care. And so I kind of went rogue at that time, if you want to say, became an outcast, because I became a licensed addictions counselor who was working with people who were taking buprenorphine in 2012. That's a rough place to be. Well, didn't have anything to lose at that time, actually began to interface with the criminal justice system a little bit more and began working with clients. There's not only adult drug court, there's family preservation court, where one of my first clients I worked with that was on medication-assisted treatment with the court system is that they would not allow this person to be in the family preservation court because they were on medication-assisted treatment. But they made an agreement with me if I'd be willing to help this person at my agency, they'd let her do all of the stuff with me and then she'd still be able to get the benefits of being in family preservation. This was back then. I talked to a friend of the family about 3 to 4 weeks ago. She's doing fine, and she got her special needs child back. I just want to make sure you get that part of it. She had a special needs daughter, and that child was taken away from her. And if they wouldn't have found a way to let her get access to medication-assisted treatment back then, she would not have gotten the rights back to her child. And she's still doing well today. So just a brief thing, medication-assisted treatment. Key things it can do is reduce cravings and withdrawal symptoms, block the neurological pathways, induce negative reactions when the substance is taken. The key thing is that it is medication-assisted treatment, not medication-only treatment. And I'm going to talk about some of the challenges that even for prescribers who are actively wanting to get this the support with the counseling, that they're having some issues with barriers as well. There's barriers that exist with agencies, like as far as a traditional intensive outpatient or an inpatient unit. So I'll give you some of that information now. So when we were doing this stuff with LSU, going ahead and putting together a source for referrals. So I'd go to inpatient treatment unit. They would be willing to prescribe them Suboxone, buprenorphine, maybe even do the injectable Sublocade. The problem is once that person is actually discharged from that inpatient unit and they've been under medical care, that medical care stops at discharge. One of the most difficult things you have then is what do I do with that client, that patient, where do I send them? Then you talk about, it was a previous presenter talked about the philosophies of treatment. You have to go down and try to see if you can find someone who shares the same philosophy of treatment that would allow this person to continue on with the treatment regimen that has been working for them. And so that has been an issue. I can say that in our area we've made some pretty good progress. I want to give you guys some hope. Even in the adult drug court, now it's mandated if you are an adult drug court provider, you cannot prevent someone from being in an adult drug court who's on medication-assisted treatment. Not only that, our sheriff's office, our local jail, Lafayette Parish Correctional Center, if a person is actually prescribed buprenorphine, Suboxone, and they go on a sanction like for probation and or adult drug court, the jail has agreed to give them their medication while they're there on the sanction. Because that was the thing that was bugging me at one point. I wasn't against buprenorphine, I was against the fact of putting someone on buprenorphine and sending them into forced withdrawal for 3 or 4 days, and when they first get out of jail, what's going to happen? You know, they go use, and the potential is, depending what's going on, they might still have some of the effects of the buprenorphine, so they try to break through that, and then they overdose. So that was more of a challenge. So we worked as a community, and we were able to get that overcome. One I don't have on here talking about the drugs, and I don't want to spend too much time on things that have been talked about already, but Sublocade is something that I'm hoping that we'll have more of the plans begin to pay for. Same thing as Vivitrol, where you can get the 30-day injection. There is a way that you can get injectable dealing with buprenorphine, and that has made it a lot more acceptable with a lot of people who were concerned about diverting medication. The question is always, you know, if we put these individuals on buprenorphine, Suboxone, that they're going to take it, they're getting it, diverting it, and they're selling it. I was concerned about that. I had to go through somewhat of a change because the way that I was trained, as it was a very direct approach. It's abstinence only. That's the way we came up. Finally, I went to a national conference, and the doctor put it very plainly for me. He said, look, this is the thing. If a person has tolerance built up for heroin, for opioids, for opiates, it's no way they're going to get high on the buprenorphine. It just can't happen. Now, he can't say that wouldn't happen to someone who does not have tolerance. But he said if they do meet criteria for a severe opiate use disorder, have been using daily at large amounts, there's no way they're going to be able to get high on the Suboxone. It's just not going to work. So I went to do some of the research for myself, and what he's saying is correct. But that doesn't mean that some individuals who don't meet that criteria maybe can't get an effect from using that medication. So I'm not saying that at all. And I'm not a doctor, not a prescriber in that way. Do the research for yourself. So LaSOR, the Louisiana State Opioid Response. LSU Health Sciences Center in New Orleans is part of the Louisiana State Opioid Response. There's several parts of this. Some is in the criminal justice system. Some are dealing directly with the opiate treatment providers, the OTPs. On the next slide, I'll talk a little bit about all the different acronyms so you can understand who we'll be talking about. The goal is to increase medication-assisted treatment. Really, the key thing is we need to increase access. All right, everybody knows that it's very difficult to get access to medication-assisted treatment unless you have the money to pay for it or your family wants to keep you alive, so they'll pay whatever it takes for you to get medication-assisted treatment, which may mean a $300 doctor visit, $200 doctor visit, plus the medications, and that can become very, very difficult. I can say that Medicaid is paying for more of the medications now, and with the Louisiana State Opioid Response, and the state is working right now towards a change in the way that they reimburse to make it affordable to where doctors can take this on to their practice to do this and actually do it in a way that they can survive. Because we all know it's tough on what the reimbursement rates are for Medicaid. And they're also working on changing some of the reimbursement rates for opiate treatment providers. That are your methadone clinics, which we only have 10 in the state of Louisiana. They may even, there's some talks about potentially taking the moratorium off, because as of right now, if a client or a patient needed access to methadone, there's only 10 places in Louisiana that they can go to get it. So ours is in Breaux Bridge, Louisiana. So in Region 4, which covers, let's say, Opelousas, if you're in Opelousas and you need methadone, it means you got to drive to Breaux Bridge. If you're in New Iberia, you need methadone, you got to drive to Breaux Bridge. If you're on the south side of Lafayette going into Youngsville, if you need methadone, guess what? It's just rough. And where the clinic is in a rural area. You have to have transportation. It's just very difficult for some people to have access as far as there. All right. We want to enhance and expand the capacity. The goal would be, as we implement this collaborative approach, that this would, by the time this project starts to come to an end, the actual prescriber has a good functioning working practice to where they can continue on even beyond the project. And part of that is with the LMHP, the licensed mental health professional and the registered nurse. We go in and do some screening, as for screening, brief intervention, referral to treatment at the actual OBOT. And we're going to talk about what an OBOT is, what an OTP is. We're going to talk about what a SCAT team is. But we go in there and help to give the support that they need to be able to launch this. So a previous grant that I was involved in was with LSU out of Baton Rouge, was for SBIRT. And for those who are familiar with SBIRT, one of the challenges we had when we implemented that grant program, we went into doctors' offices, trained nurses and other healthcare providers of how to do SBIRT, but their question was, how do we afford to implement it? What do we do? How do we make this work? And with the Louisiana State Opioid Response, what we're doing with the OBOTs, there's a way actually now to implement it and really integrate this into the opioid epidemic. And I'll talk to you more about that as we go along. Let me make sure I'm good on time. All right, so hub and spoke model. So the OTP is your opioid treatment providers. That is the hubs. That is your methadone clinics. There's one in each of the 10 regions in the state of Louisiana. So you have one in this area, and like I said, and so with the SCAT teams, their main function would be is to serve as a liaison between the opiate treatment providers and the OBOTs. And what are the OBOTs? The OBOTs are the office-based opioid treatment providers. This can be a regular intensive outpatients licensed addictions clinic. It can be a physician. It could be, you can actually get waivers as a nurse practitioner or physician assistant, but it could be in a doctor's office. It could be in a clinic setting. It could be in a hospital. It could be in an FQHC, which is a federally qualified health center. And again, the spoke care teams, which the SCTs, you'll hear it's considered to be SCAT teams. There's another term with the Office of Public Health, OPOCs, the Outreach Prevention Coordinators. They're called OPOCs. So you start hearing, as you engage the opioid epidemic and what's being done as part of the Louisiana State Opioid Response, you might hear about OBOTs. Well, that's just the clinics that are being licensed throughout the state. In each region, there's going to be 5 that can be licensed within each region. And so in this area here, there's an option to get at least 5 clinics, which can work along with LSU as part of the state opioid response. So if you look in the 10 regions, we'll have up to 50 in the state of Louisiana. And at the end of the presentation, I'll have a website where you can write down. You can click on that website, look in your region, and find out exactly who those actual office-based opioid treatment providers in your area. And I believe in this area, they're still recruiting some providers. So there is a couple of individuals that are here that work as part of the Louisiana State Opioid Response with LSU from this region, and they'd be more than happy to talk to you guys to give you some information about that. And this is the actual web address, but don't worry about that. It's going to be on the last slide, so it'll be easier for you to go ahead and write that down. When you hear about LGEs, everybody know what the LGE is? It's your local government entity. So in ours, we have the Acadiana Area Human Services District. I think here is Cato. It's basically your, when they did some changeover, it used to be your just based on a region, and they were just like state clinics. Now they considered local government entities. One of the benefits when they did that was because as an LGE, they considered an autonomous unit, meaning that they can apply and get grants and other things to expand and enhance access to treatment. Whereas if they were actually part of the state, that restricted them from having some of that access. So there are some benefits. And I can say that that has materialized with some things in our area for sure. The Acadiana Area Human Services District has done a lot with education and training about the opioid epidemic. So this is from the previous grant. These slides I'm going to go through is really just to give you an overview and hopefully to encourage you that this might be something you want to look into. The SBIRT initiative is a nationwide initiative. It was used also with the veterans, and it's been used in quite a few SAMHSA grants, which means if you do a little bit of research, you can find some very good training for SBIRT online at no cost or very little cost. So this is an evidence-based practice you can implement that you can get done at little to no cost. Myself, and there's probably about 25 other trainers in the state of Louisiana. We went through a train-the-trainer as part of this particular grant, and we went out to train others on how to implement this. And there was a second wave where LSU went out at the sites who implemented this and actually trained people within the site who could then train others. So let's talk about what SBIRT is. Screening, brief intervention, and referral to treatment. All right, so basic universal screening. When you're doing SBIRT, you're not looking to diagnose. You're just looking to see either screen in, screen out. Patients in your office, and looking at this from a medical standpoint, you can go through the basic screening for alcohol use disorder, potential screening for substance use disorder, anxiety disorder, also depression. Most of your, I'm not sure about the exact regs, but I'm doing some work with a couple of doctors' offices right now, and they're saying for them and also for hospitals, this is almost standard. There's certain screening that has to be shown that you're screened for potential substance use and mental health. If you implement SBIRT, it's actually something you can do, and it is reimbursable on Medicaid. That when they did the SBIRT initiative, you look into it, it is an actual evidence-based intervention that can be placed within the clinic that can actually be billed for. And that was one of the benefits of doing that. And it does not have to be done by a licensed mental health professional or a nurse. It can be done by trained clinic staff. So it can be part of the intake process. The primary goal of SBIRT is to identify and effectively intervene with those who are at moderate or high risk for psychosocial or healthcare problems. With SBIRT, it's not only looking for people who may present with a potential opioid use disorder, but you want to intervene with people on the earlier end as well. If we just wait till everybody gets sick enough, part of what really pushed me to design, develop, implement programs in our area, work with the criminal justice system, I remember taking calls from parents, and they'd be looking for resources for their kids, and I'd almost have to tell them, look, unless your child gets in trouble, kicked out of school, or considered ungovernable or something, I don't know where to send you, especially if you don't have the money to pay for it. That was a hard thing, but it was the reality in our area, that once they got into some type of trouble, there was these resources. If they weren't in trouble and they were just struggling, there was no resources. These are some ways you can identify individuals and maybe when they're struggling. And the whole premise behind SBIRT, and there's data to back it up, it was a thought that if you go into your doctor's office, your health professional, your primary care physician, the thought was that people would not be open and describe or talk to their doctors about what's going on if they ask them about alcohol and or substance use. The research proved that to be exactly wrong. They found that people were more likely to talk to their medical professional than they were to somebody else. Actually, in some cases, more likely than they would if they had put them in the office with me as a mental health professional. They've been knowing that doctor for a while. We work in that particular clinic in Lafayette that's part of the Louisiana State Opioid Response. And it's always interesting when we go to do the consultation. We meet with them, the licensed mental health professional, the nurse meets with them, the nursing staff at the clinic meets with them, and then they meet with the doctor. Some depending on how the psychiatrist wants to do it at the time, we might meet afterwards. We all met with them, or they meet with us before and again afterwards. What's unique is that there's certain things that when they get in the office with that psychiatrist that they have not shared with anybody else. And just using the right type of approach when they're in the office. And the psychiatrist is only spending, from what he's saying, an extra maybe 5 minutes to be a little bit more empathetic and is getting some extremely valuable information. But the challenge that the psychiatrist would have had is that, yes, I'm prescribing the buprenorphine, I'm taking care of these needs, I've identified these needs, where I'm going to send them and how I'm going to get them there. So part of what we're doing as part of the Louisiana State Opioid Response, we're in there, we can help them to get access to other treatment resources, make some referrals, educate the staff at the actual clinic on, here's a resource manual, this is a place you could send this person who has transportation issues. One of the clients that come to mind, an issue was, he's living in one city that's 50 miles away, and he comes to get his medication here, but then another 15 miles west is where his actually pharmacy was. Like, oh, so we sat down, just had a good motivational interviewing type conversations, trying to identify barriers, seeing what we can do to help him, and come to find out the person just didn't have an ID. All right, so the reason he was going from close to Baton Rouge, coming to Lafayette, and then going to the Acadia Parish to a pharmacy is because that pharmacy is where he had grown up, and they'll be the only people who would give him access to his medication. So guess what we did? Got him access to an ID and made his life a whole lot easier. Not to mention, he was depending on a ride. He's staying in an actual independent living type setting. He doesn't have his own transportation, so he's dependent on someone and they're bringing him all over the state just so he can make it. Now he is struggling, and now we're working on the next phase is to get him connected to an actual, we looked at trying to getting him an actual counselor in the area where he lives, but that proves to be more difficult. Using motivational interviewing strategies, we were able to determine that it's probably easier because the person is motivated to go get them and bring them to the clinic where they get the medication, where he can get the counseling in Lafayette, either right before he comes to the clinic or right after he leaves. And that's going to be a better chance of him being successful in getting the counseling. The beauty I like about this, when a person truly needs this intervention of medication-assisted treatment, when they come in at a 2-week follow-up and you see the person who was going through some severe withdrawal symptoms, and then they come back and they're just looking 10 or 100 times better. But then now they're present enough to tell you that I have some serious issues now. I'm struggling with cravings. I'm struggling with this. I have transportation issues. I have all these other barriers now. Why? Because the crisis is over. And often what we tend to do is address the crisis. And then once the crisis is over, we send people on until they come back with the next crisis. This is, I hope we can get more on not just with early intervention, but also some prevention and help people get to that maintenance phase. Insurance companies only pay for crisis. Once a person starts doing okay, not better, when they're just no longer in a crisis, there's no more reimbursement. And so we've worked out some things, even on private practice. I do some scales where if insurance stops paying, I'll give them a flat rate. If they want to keep coming, they can come long enough until they feel they're ready to discharge, not because so-and-so said you had to discharge. All right, screening is the first step of the expert process and often precipitates patients' self-reflection on substance use behavior. And when you think about screening and when you're doing an expert intervention, if done effectively, you can take a person who didn't realize that they were struggling, and through a simple 5, 10, 15-minute conversation between screening and maybe a brief negotiated interview, this person is telling you, I think I might need to do something about this. It's powerful when you in a non-judgmental way when you do a screening. Because when they are asked about alcohol use, substance use, depression, anxiety, and that's done in that nice, concise way, when's the last time, or have they ever sat down and really took 15 minutes or so and really think about their life in that way? So when they have to sit down with you and answer those questions, and also you need to be trauma informed at that point, because if the client may have had a history of trauma, again with females, you're looking at about a 70% rate. There's a substance use disorder, they've either been exposed to or have experienced a trauma. So if you work with females that are in recovery, being trauma informed is imperative. That just means the majority of your population has been exposed to trauma. All right, so the audit is an easy tool you can use. It's in the public domain. It's used in a lot of grants. It's developed more involved with the World Health Organization. It can be self-administered to where they can do it themselves as part of the intake process, or it could be administered by someone in the organization. I'm a clinical supervisor, so I train new counselors. So one of the things I like to do to give them some good clinical experience, often the universities will send them to you at no cost to try to get some help. Let them do all your screenings. It gives them some good interaction, and you get a little bit better response than what they do when they fill it out on their own, but you'll still get good results in that way. Key thing on the audit, we live in the state of Louisiana. Make sure you understand what is one drink in Louisiana. Anybody here from the South Louisiana, New Orleans area? Yeah, anybody know about a Long Island tea? All right, how many drinks are in a Long Island tea? At least 5. Especially, I went and seen somebody at Pat O'Brien glass, and their Long Island tea was like that in the glass. I remember when I was young, it was the whole Pat O'Brien glass. Yeah, that was in 5 to 10 drinks. Well, I just had 1 to 2 drinks when I go out. Well, they had 10 to 20 drinks if they were drinking some of those type of drinks. We've been to certain places that they talk about the beers they drink. Make sure you understand what size beer, what type of beer, and what they're doing. So when you're screening, you might have to do a little follow-up, and there's a nice little chart so you can find out. 5-ounce glass of wine is considered 1 drink. So I'll ask that to some people. I'll drink about a bottle of wine. I'm like, So drinking to intoxication is 3 to 5 drinks in one sitting, right? 3 drinks in one sitting, 5 in a day. Now that doesn't mean that, that's more of a standard looking towards a diagnosis or, more high-risk drinking. But they might drink that bottle of wine in only 2, maybe 3 glasses. I think you had a...
Regarding beer, people don't realize craft beer has substantially higher alcohol. Commercial beer tops out at 4 or 5%. Craft beer starts at 6.
And one that's a little stronger, let's say you're at 8, then 1 beer is 2 beers. So when they say I've had 2 to 3, you're thinking, that's okay. They've had what? 4 to 6. Education, and I agree with the previous presenter when he said that I have become an overeducated addictions counselor just because our clients are the ones who do the most education for us. When you utilize motivational interviewing, it's a very collaborative approach. I'm going to just briefly go over some of that stuff. A lot of slides. This presentation was designed to be done in like a day, so I'm going to give you some overview in an hour. But these are key things, and there's actually charts that are out there where you can actually make a copy of this and sit down in front of them and say, oh, well, if that's the case, then I guess I'm drinking 5 glasses. All right. So this is the audit. Basic things, self-scoring, gives you an idea. There's certain questions looking at hazardous alcohol use, dependent symptoms, and harmful alcohol use. I do a lot of screening for, like I said, OWI clients, and there's a strong correlation between using alcohol in certain health conditions. And it's unique that, I know we're focusing on opioids, but just wanted to give this little information about alcohol, because medication-assisted treatment can be used for alcohol as well. When you're sitting there and you're working with the client, and then they have to go abstinence-based now to be in this diversion program to get this OWI off their record. And they come back, maybe do a follow-up in 6 months, and they tell you that, well, I'm taking half the medication I was taking before, or my doctor has taken me off of this particular medication. Well, just from not drinking any more alcohol. And I think for women, the number is around 7 per week. Anything above the 7 would be considered harmful. And this is from a medical perspective. We're not talking about from a diagnosis of a substance use disorder or alcohol use disorder. And men is around 12 based on the biology. But, and I know where we live in South Louisiana, the 12-pack, you're lightweight. So, 2 to 3 times in a week or twice in a week, you're drinking a 12-pack, a case in a week. It means you're double to triple what would be considered, harmful use. Now, though the person may not have, a diagnosable alcohol use disorder, they may be experiencing issues with blood pressure. They may be making their diabetes more complicated. There's a lot of things that they could be suffering with that the alcohol is having an impact. All right, the GAD-7 is a screening for anxiety. Again, this is in the public domain. For most of the your insurance carriers now, if you're doing more in the medical as a primary, they want to know, are you screening for mental health conditions? Well, GAD-7 screens for anxiety. And the PHQ-9 screens for depression. So you can meet the criteria for using the audit, the GAD-7, and the PHQ-9. You've now screened for alcohol use disorders, anxiety disorders, depressive disorders. There's another one called a DAST, it's the drug abuse screening test, which if you look and you find the World Health Organization dealing with the audit, you'll see the complementary test for substances. So you can do all 4, and guess what? You don't have to do one of those expensive things of buying some license to all of these instruments so you can use them. So they're available. They come with scoring sheets, and you can implement them. All right, so when we're doing an expert, we're looking at a few things. Doing a screening, someone may just have some low risk or maybe abstinent, and what you do is your screening, just give them feedback only. Some of that feedback would be using, like rolling your O's, would be opening the questions, affirmations, reflections, summary. So for that person, you may just encourage them by giving some good reflections and affirmations about how great they're doing, and encourage them about what they're doing, how positive that is for their health. And what this will do, if you're in a practice and you're doing the screening, you may run across some highly functioning people who have a severe opioid use disorder. One way to do it is if they have the resources to support it, you can have a high functioning person with a severe opioid use disorder in your clinic on a regular basis. Oh, sorry. And other thing, we talked about the risky or harmful, we can do a brief intervention. We're going to talk about that for a minute. And when they're at severe or dependent, if you don't provide that level of care, then you can refer them to treatment. So American Society of Addiction Medicine, ASAM, levels of care, which is pretty much the standard for substance use disorders in the state of Louisiana. One level of care that is rarely used, we use it very much in the practice that I have as far as private practice, is level 0.5. Anybody can tell me what 0.5 is in the ASAM levels of care? It's called early intervention. That's that big group of people that had the risky or harmful use. Anybody in here done EAP work, employee assistance programs? Then that's that client that is struggling, they're subclinical, they don't meet diagnosis, but with a good intervention, the primary age group I use this on is 18 to 26-year-olds. And I see some individuals who are struggling in college or at a young age. We do 5 to 6 individual sessions and see phenomenal change in their lives because we implement an early intervention. And their situations are very unique. And if you can go through the process and see what it is to make sure that you're using a very client-centered approach, where it's an individualized treatment plan. Again, assessment on the first session. If you do EAP work, you got 4 to 5 sessions to make the magic happen. If you can't do it in the 4 to 5 sessions, then you should be doing, ethically, referring them on to treatment, because there's no way you can get them to a good outcome at the end of those 6 sessions. Now, that doesn't mean that in session number 4, even though they're doing well for whatever reason they came, they might not bring up they had some type of sexual trauma or something, and then you just have to deal with it. So it's not a perfect world. It happens. Sometimes that was the best intervention you did. You had a good clinical relationship. That person felt comfortable enough to now share with you something that they would like to address, and then you have to refer out for them to be able to address that. So that still would be considered a successful intervention. You close out on what you had, and you refer them to what's appropriate. But that particular risky or harmful use, the data we have that was part of the expert training showed that only 5% of the population would meet criteria for an alcohol and or substance use disorder, right? You know, as far as the people you're looking at that are actually using substances. That risky or harmful use, that's like representative of about 20% of the population. Remember when I mentioned about those kids that were having trouble, but yet we didn't have resources or anything for them yet? We have a system set up to where people have to get sicker before they can ever get help. So we have a culture that we're missing a whole 20% of the population who's experimented with opioids as well, have not gotten into a severe problem, but we're not even touching that part of the population. So what SBIRT will do is allow you to identify those particular people, and there's interventions you can use in order to address that population. Very low cost interventions, like I said, 5 to 6 sessions. And I usually tell clients who come in to pay for that, if I do my job effectively, I'll save you enough money in 6 months that then after that, all the rest of the money you save, you get to keep. You know, just pay for that little 5 to 6 sessions, and I promise you, if we're effective, it'll be a financial benefit to you, and we see it happen all the time. So the brief negotiated interview is a semi-structured interview process that's based on motivational interviewing principles. A brief intervention can be completed in 5 to 15 minutes, which is great if you happen to be in an actual clinic, FQHC, like Federally Qualified Health Center, or even a doctor's office. That means if you have those particular patients that are coming in and they're scheduled at a time because they're more high risk, you can create somewhat of a clinic, the same way you might create a MAC clinic. You can see quite a few people in a 3 to 4 hour period. And having just an actual contract social worker, addictions counselor, licensed professional counselor can greatly enhance a person's practice. And with SBIRT and some of these that are interventions that are there, they are reimbursable. And so it would not be an actual deficit to the company. It actually can be something that could be implemented that brings in revenue. Brief intervention is a brief motivational and awareness raising intervention. When the previous presenter talked about the stages of change, the trans-theoretical model of change, pre-contemplation, contemplation, preparation, action, maintenance. The way I normally explain it to clients, because if I use these interventions, I educate the clients on what it is that we're doing. Basically, if you're in pre-contemplation, that's before you started thinking about it, right? If you're in contemplation, now you're thinking about it. So if I have a client or a patient that has not been thinking about those things yet, I haven't raised awareness, they may not know that what they're doing is actually risky. If you have a client that's taking opiate medications, opioids, and they talk about their eating pills, anybody been doing this for a while, the average person doesn't eat pills. But that's the type of language you have to understand, knowing individuals who are actually using substances at a high rate. You know, they eat pills. Other people might take pills. All right. So you're basically finding personal and compelling reasons to change, building readiness to change, and making a commitment to change. Often what the brief negotiated interview is, you're just working with the client, the patient, to feel comfortable enough to make a decision that they might want to try to get some additional assistance as far as in what they're struggling with. Because it's hard for them too. Imagine you being on the other side and you went to your doctor, they seen some labs, they talked to you like, well, you know, you might need such and such medication because of your cholesterol or your whatever the case may be. That initial feeling you have about it, like yeah, I know I probably could be doing something different, but you can't tell me it feels good. So you do this screening, and now this person who thought their life was good, right? They're a lightweight. They're just drinking 12 to 24 beers, or, I just use a little bit more medication because I'm in pain, right? What they considering a little bit more medication is based on how they've been getting that medication, which they probably were over-prescribed at that time. And when I worked in the doing intensive outpatient around 2007, 2008, it wasn't uncommon for somebody to be taking 30 Lortabs in a day, right? Then they went to oxycodone, right? For those who are not familiar with the process, I'll give you the evolution. So they go from Lortabs, and then you have, the way Lortabs are designed, it starts causing you some stomach problems, right? Well, then they went to oxycodone, right? And it's supposed to be time release. What they do is they crush them. Well, then they changed the formula to where if you crush them, it didn't work that way. So they crush them, say if it's a 30 milligram pill, you crush it, you can get all 30 milligrams at once rather than getting it over time. They changed the formula. What became popular then was roxicodone. And you can get some very high doses with roxicodone. Then we came up with the best response. And you know what we did? So we're not going to prescribe you anything anymore. No medication-assisted treatment, no intervention. We're just now going to take away what you are physically dependent upon. And what happened? Yeah, now we got heroin at a very high rate. So we can be really excited about our prescription rates went down for oxys and roxys and Lortabs or Narcos. And now we're also talking about how much of a rise we've had for heroin. And I tell you, y'all should be alarmed. I screen young people, and there are young people who are not going through what you would call traditional routes. They're trying methamphetamines, heroin as first option drugs. Have never tried anything else, and they're just experimenting with those drugs. This is a very dangerous time we are in that. Also, we're going to talk about the technology of drugs. Looking at cannabis, I've been predicting for the past couple of years that somebody was going to die of THC, and I was like, not marijuana. And challenge the young people, oh, Mr. Wynn, that's never going to happen. It says the technology of drugs. If you take cocaine in its natural form, could you overdose? A bunch of coca leaves, chewing that all day. If you can chew on enough coca leaves to overdose, man, good luck. It's just not going to happen. Then it was put in liquid. Then you had it put in a more crystallized where you could snort it. Then eventually it started being smoked and actually used IV. Now that same drug that you could not chew enough, right, to die from, what happens if you go ahead and start shooting it up, doing it IV? Is there a possibility you can overdose? Even at the crystal format, as far as depending on what the person's tolerance is, they could do enough cocaine. So I would always tell them, I said, in its natural form, you can get you regular grade marijuana and smoke all day long. Y'all are right. Was the chances of somebody dying slim to none, or there might be some other complicating issues. But there's teenagers right now who are in your midst at times that are doing very potent, the DAP pens. They're doing the value of sometimes a quarter pound of weed within an hour. And it has no smell, so they're doing it in grandma's living room. They're doing it even with younger people, let's say, could be older brothers or sisters that are 26, 27 years old, who just are not aware of the culture. And so now what happens when you're taking in that level of THC, at also the level of the way that they're ingesting it, the route of administration through these DAB pens, and now we have people going through some serious problems, lung problems. Now, I'm not saying that THC is what killed them, but it's still related to those THC cartridges why these people are ending up in the hospital. It's the technology of the drugs is what's causing them to be in trouble. Same thing when we're looking at from the opioid use disorder is we can look at the fentanyl. And I don't know if the guy from DEA spoke at this particular symposium, but if you look at just heroin, fentanyl, and carfentanyl, the amount that it takes to kill somebody is so small, it's like grain of rice size. The technology of it, we have the purity of drugs that someone goes and they've been locked up for 4 years, their criminal justice involved. They come back thinking, I'm going to just try something on a small amount, what I did before, first, week out of jail or prison, and they're dead, overdose. They had no idea what they were getting involved with. All right, so brief negotiated interview we talked about. I want to get to the principles of motivational interviewing is to express empathy, support self-efficacy, roll with resistance, and develop discrepancy. And so I'd like to take most of the time is bringing this to a close and thinking about how addiction treatment was done 15, 20 years ago compared to how it's being done on more we call the evidence-based practices, but we're really the most successful interventions right now. It's not a directive approach. What I would challenge you to say that most clients who come into your office who have a substance use disorder know they have a problem with addiction. So being extremely directive and confronting them initially when they come in there, if they're in front of you, they got a problem, right? Either they're there trying to avoid something, somebody sent them there, they're trying to hold on to a relationship, they're trying to keep their kids. Something has happened that's got them in a bind, or themselves, they just can't handle what's going on. Support works a whole lot better. For those clinicians in here, if you've never studied about functional family therapy like FFT and the premise on that strength-based approach, we use this with conduct disordered, very behaviorally disruptive children, and it's all strength-based, no focus on problem or diagnosis, and the results were phenomenal. And it had an awesome effect that when you go in this home, treating them with empathy, respect, and care, it was having an effect to where it was rolling over to all the other people in the house. Because when you go do the intervention, it's not at your office. You go in the house, where the situation is, teaching them. Probably the primary intervention we used with functional family therapy was communication skills. Just building communication skills where it can be effective in the home created, just phenomenal results. So we talked about that, depending on the person's stage of change, this gives you a way to kind of put an overview of where a person is. If a person is in pre-contemplation, you look at what the intervention, the goal is to bring them to contemplation. You want to raise awareness. Hopefully you can get them to see what's going on where they can then say that, well, know what, I might have a problem. Now they're thinking about it, right? They move from pre-contemplation to contemplation. If you have a person that you're working with and they're in contemplation and they're ambivalent, well, I might not. They talk to you one night, man, I need some help. The next day, I'm good. Or it could be in the same sentence or same day, they're struggling. They're thinking about it, they're not sure. What you want to bring them to is what's called decisional balance. All you want to do from contemplation to preparation is get them to make an agreement that they are willing to change, right? And once they're in preparation, that whole phase of change is just where they call it here, it's about determination. The preparation determination phase is just getting them to make a plan and commit. Once they commit, you get to the action phase where they're actually doing the work. If this sounds a little strange, it should, because often what happens is when we get someone in our office, we go from pre-contemplation and we tell them straight to number 4, this is what you need to do. What self-efficacy is about, that person believes that they can change. It's okay that you believe that client you have in your office can change, but it's not as powerful as when they believe they can change. And what you want to do is help to build self-efficacy to where when they get into action stages of change, you'll have good outcomes. We do this with clients with opioid use disorders and methamphetamines. It's become, to me, this is the new epidemic I see. It's not really being talked about as much, but there's a lot of IV methamphetamine use. It's on the rise, and now it's not uncommon to have them doing both. But I have some that will say, I'll never touch heroin or any opiates, but they're shooting up meth on a regular basis. It's a major deal. All right, so MAT can reduce the cravings, block the neurological pathways. This is more of a review. And what triggers change? Motivation for change is an accepting, empowering atmosphere that makes it safe for the person to explore the possibility or the possibly painful present in relation to what is wanted and valued. So, philosophy of treatment that I use now that's based on evidence-based practices, if you come and you're going to engage myself or people I train or clinics where we work, it's about creating a safe space. Trauma-informed is going to be there because people can feel comfortable enough. And then, the thought before was that the old belief was always about just avoidance, seek pleasure, avoid pain. But if you can get a person in the office to feel comfortable enough, you'll be surprised what happens. I have mandated clients who, at the end of their mandated time, don't want to leave. They still continue to pay. When I was working at the sheriff's office, you'll like this one. We did this it was called the rehab program, reentry housing for addictive behavior. We had clients who were pre-trial, meaning they hadn't been sentenced yet. They go to court, get sentenced, and can go out on probation, right? The program was 6 months. That happened about 3 to 4 months of them being incarcerated. They would opt to stay in jail to finish receiving the services for those 2 months rather than going home. That's what happens when you create a safe enough environment and you give them what they need. And if it can work in that situation, just imagine if we can use that with all clients. So ambivalence. All change contains elements of ambivalence. You want to change and you don't want to change. The goal is just trying to help people to get to that point of commitment. All right. So last thing I'm just talking about, the frames approach when using motivational interviewing. You get feedback. Next thing is talk about responsibility, working with clients. Just because you're doing a non-confrontational, engaging environment doesn't mean that the responsibility doesn't fall on them. If I'm going to skip to the end of this part, the frames, and just go to the oars, because I think that probably speaks the most to it for the time we have left. It's called rowing your oars when you are using motivational interviewing. Ask open-ended questions, give affirmations, reflective listening, summary, and you want to elicit change talk. The reflective listening is a powerful intervention in working with clients because most of them will come into your office feeling unheard and not understood. So if you can sit there with a client and just reflecting back to them, reflecting of content, reflection of feeling, and they know that you're listening and hearing what they're saying, you can watch them to begin to now give you more and more to work with in order to bring about change. All right, so I'm going to get to this last slide that I want to talk about. And making referrals, dealing with individuals, and looking at this from the state opioid response. When people are dealing with, it was talked about earlier, post-acute withdrawal symptoms, they're dealing with withdrawal symptoms or potential with, it's a biological, physiological problem, looking at it from a Maslow's hierarchy of needs. Counseling is not the thing they need at that moment. They need to be stabilized. One thing that medication-assisted treatment can do for our community, which is a lot better than the old way, if you ask me, when a person came with a severe opioid use disorder, what was the prescription? Detox, treatment, halfway house. How long were they going from home? Yeah, anywhere from, if they decided not to go to halfway house of sober living, at least 30 to 40 days, but on average, 6 months. With using medication-assisted treatment, if you can stabilize them in 1 to 2 weeks on the medication, you can now work with them within the community, build a community, help them along without ever having to send them away for 6 months at a time. The next relapse, what would happen? Another 6 months. I'd work with clients to where in a 15-month period of time, they might have only been home 1 month. They haven't broken any laws, but they feel like they're being treated like prisoners. Medication-assisted treatment helps to address that. Public health versus public safety. Public health is what we're talking about with the harm reduction model. Public safety, not only trauma-informed, I think there's just another way we need to look at, and that's being criminal justice informed. Many of these clients are criminal justice involved or DCFS, Department of Children and Family Services. We got our office, my private clinic, certified with all of them. That way when a client came to get help, they didn't have to replicate. I don't know if y'all have to deal with that. They'll be doing well with you. Say, oh, but you got to go through this specific provider. Each agency they dealt with, they each had to go to a specific provider. In our area, if they come to our place, they're good with everybody. We also do EAP programs, and also the SAP evals for Department of Transportation. Once it goes out and you're looking at making referrals, is looking at the stigma. It was talked about, and this is where I kind of ended. Just know out there, not all philosophies of treatment are the same. Not everybody feels the same way. I know in this audience, there's probably people who still don't believe in medication-assisted treatment, and that's okay. But be aware of what the philosophies of the place that you're sending referrals to. And I had one particular referral that happened about a month ago. They sent them someone, they were forced into withdrawals because that particular prescriber did not believe in using Suboxone, only Vivitrol. So they went to a certain point, certain amount of days, and then that person was extremely sick. And they went from being on a good course of treatment to in crisis because they went, someone who thought they were doing the best at that point didn't really understand the philosophy of where they made the referral. And actually now the client, you just lost therapeutic relationship because you just sent them to a place that they feel made them worse. So I'm at the end here, and I'll put this up. The link at the bottom is what will get you to all of the OBOTs in the Louisiana area, and it's continually updated. Hopefully there's some people here that might be interested because I know they're still recruiting for OBOTs in this area. Any questions? Yes.
And the other question, which is a little bit off topic, and it's not specifically about opioids, but and Bill, all of our chiefs and everything common as well. What kind of headway are we making in treating adolescents with? Because the only experience that I had, personally, was years ago with the drug court program, and that was basically a scared straight program. So are we changing our attitudes towards
Talking about just treatment in general? Yeah, it's what I found that some of the most successful interventions, you can look in your area, just instead of a clinic approach, there's licensed professional counselors, licensed addiction counselors, LCSWs who take Medicaid as individual providers that specialize in working with children and adolescents. And still Medicaid will pay for it. So they exist. That the standard clinic approach, looking for a clinic who's going to do that, there's not as much out there. But as far as private providers who specialize, there's a lot out there, and there's more and more people on Medicaid. Well, I will say, though, as part of the Louisiana State Opioid Response, the OBOTs, one of the special populations is pregnant women, and they are now actively treating pregnant women with buprenorphine. And I know I tried to find referral sources some years back, about 2012, 13, and could not. I found one hospital in the state of Louisiana who was willing to help someone. Now, within a 50-mile radius, I could probably send them 7 different places. All right. Well, thank you, guys. I know this is the last of the day. Dr. King.